well to ask questions through the Q&A. We'll do our best to answer them live, but also we'll be monitoring that, able to respond via the Q&A function as well. And then as we go through, and kind of wrap up the session, there will be a few questions at the end. We really invite you to respond to those. We'll also have a poll question here in a moment that we'd like you to respond to. And then you'll see at the end, if you have questions, if you want to learn more, we invite you to please reach out to PSW or Innovacer, and we're happy to share more and dive into other aspects. But really, to kick us off, I want to start with a quick introduction. So my name is Jake Woods. I'm the Executive Director of ACOs at PSW. I'll talk a little bit here in a moment about PSW, where we are, where we're from, what we do. But then I'll pass it over and let each group just very quickly introduce themselves. I'll start with Dr. Shannon.
Hi, folks. I'm Michael Shannon. I'm an endocrinologist and geriatrician, and I serve as the Chief Medical Officer of PSW. Cheryl?
Hi, everyone. I'm Cheryl Mosses. I'm the Chief Nursing Officer here at PSW, and I oversee our care management program.
Hi, I'm Brian Silverstein. I'm the Chief Population Health Officer at Innovator. I am just so excited to participate in our conversation today. And so one of the things that I really am passionate about is helping our clients help their patients. And we've got some great information to share today, and excited to learn and have a conversation.
Yes, wonderful. Thank you so much. We are very excited. So want to intro with some of our goals for today. What are we looking to get out? And we do have a quick poll that we're gonna launch right now. So please invite you all to answer those poll questions. But really, what we're here to talk about today is care management. And when we talk about care management, we are talking about building a program for value-based care arrangements. From PSW perspective, I'll talk a little bit about PSW and our experience in value-based care and in risk arrangements. But really, what is the importance of having not just a care management program, but having a structured care management program? And really, how do we use that to do more than just interact and participate with or get participation from our patients? But how do we actually generate outcomes? How do we measure those outcomes? What are the results that we're actually seeing? How are we proving the care management effect on our value-based care programs? And so really the effectiveness of them. And how do we leverage technology? That's why it's so important, the relationship that PSW has had with Innovator, and really been able to kind of leverage their technology in partnership with our services to reach our population. And so why is that important? How have we found success with that? And then really kind of overall, why chronic kidney disease management? Why is there an emphasis that we should focus on that? What have we seen from that? And Dr. Shannon has some great material that he's going to go through from success that we've had in the area. So I believe I haven't seen them pop up. Does everybody seen the poll questions? I hope those went out. Really want to kind of gauge from everyone, there we go. Does your organization have a care management program already established? Are you thinking about it? Have you not even thought about it at all? And really now is the time to start thinking about it. And then specific to chronic kidney disease management, are you interested in, learning more and beefing up a program that you already have existing? Or have you, not necessarily stepped into some of the condition specific space? And so now's an opportunity to learn more and see why it might be a focus for your organization going forward. So we'll leave those open for just a moment or two. Please vote and send us your information. We'll share that here in a moment. But kind of moving on and kicking us off about PSW as an organization. So PSW was originally founded in 1995 as an independent physician association in Olympia, Washington. The organization came together. It started with a few independent primary care and specialty care docs in the area. I always hear the story from our CEO here that it was in the back conference room of one of our specialty practices that the groups got together and they said, hey, we need to do something. We need to do something different. We need to be sure to pool our resources. We need to find a way to start participating in some of these new arrangements that are coming out. The landscape is changing. The landscape has changed quite a bit since then as well. And so they needed to come together, and that really grew into PSW as a population health company today. We now have shifted and aren't necessarily the traditional original IPA anymore, but really focusing on how can we work with all different types of providers, independent providers, critical access hospitals and rural providers, health systems. How can we help those organizations participate and aggregate risk in value-based contracts? It's so hard for some of these smaller organizations to get in and do it by yourself. You don't have the volume, or you don't have the resources, or you don't have the know-how to get in and actually do it. So PSW has really positioned ourselves to be able to help those organizations bring providers together and give them a better opportunity to be successful. And so we have since gone from the original days of our IPA and being fully delegated for Medicare Advantage to now spanning across multiple different contracts, multiple different payers. We have 4 Medicare ACOs. We are fully delegated for Medicare Advantage, that we're getting close to the end of this year. We're wrapping up 2024. We're wrapping up 2024 with the ACOs and MSSP and REACH. We've got commercial value-based contracts. We're working with self-insured employee health plans and direct-to-employer arrangements, really trying to span across the board. How can we help all these providers in all these different types of arrangements? And so now, we've built out our systems. Care management is a piece, claims processing, quality reporting, risk adjustment, utilization management, really kind of getting the full portfolio of services for these organizations to be successful in these arrangements, and are now supporting over 400,000 lives across Washington state in some sort of value, quality, incentive type arrangement with our partners. So PSW has come a long way since 1995. Built some great partnerships, such as with Innovacer and with various different types of providers, and really excited for the future and where the landscape is going. But really want to start talking about building an effective care management program, and want to share those results on the poll. I believe we have the ability to make those live. So hopefully we can kind of pop those up and see what we're looking at with everybody that's attending today. But really want to emphasize the need to have, like I said, have a strong care management program that's actually working towards outcomes and not just participation, but also then thinking about how we engage with our patients, and making sure that, this is not just okay, you go here, you do this, you do this conveyor belt type process, but how can we really focus on creating informed individuals that understand a little bit more about the health system, because we all know how horribly complicated it is. So how can we make sure that we do our best to translate that to them, and then help guide them in the direction, make them aware of the resources they have, make them aware of the decisions that they're making, and how they can work towards better overall health for them. And then how can we can support our entire population in this effort as we're working with our providers, and working in these contracts. So really taking that holistic approach, promoting wellness, promoting autonomy, but then also thinking about why is it important to have certifications. We have achieved an NCQA certification for our care management and population health program that we're very proud of. But really what that comes down to is, how do we start to build standardization and scale? And that is so important as we're growing to different types of contracts, as we're growing to different types of providers that we're interacting with. Every patient is going to be different. Every type of provider is going to be different. And you can't have full standardization, off the shelf, but how can we get our programs really as tight as possible to focus on the highest risk patients, focus on the most impact opportunity, and really kind of build that care pathway that is going to give the best experience to the patients as possible as we go through. And so we see, very key important levers for population health. I don't know that this is necessarily groundbreaking for anyone who has experience with value-based care and population health. If you're newer, maybe this is still kind of makes sense and is relevant, but this is where we've really found the focus to be for care management to be effective at the population level. Acute care, post-acute care. There is a huge opportunity in post-acute care. And we've really found that working with those post-acute facilities effectively can have a massive impact on your value-based contract. And then really kind of thinking what we're calling our standard services bucket, right? Where are you going? Are you seeing your primary care? Are you using urgent care where appropriate? Is there in-home opportunities? Are we measuring, tracking, and working on social determinants of health and coordinating with community-based organizations? We all know that that's a big effort coming out of CMS and the Innovation Center and the administration. It's something we all want to work on, but how do you do that effectively? How do you take in all of that information and really put it together to make an effective program? So I think for us, what we really can do and what we have done with our patients is just provide as much education as possible, as much interaction with the patients as possible, really move them through that care pathway. And then, like I said, kind of narrow down the population. How do we find the highest risk, the highest impact patients that's actually going to make a difference within your value-based care, your population health program, make a difference to those individual patients and kind of make their care experience better. And so for us, we've kind of built that around what we call our three main buckets, that are our care management program. And then, here in a moment, we'll move over to Cheryl to actually start talking about some outcomes. But really what we found is that there's kind of three facets of care management that we really focus on. Rapid recovery care, focusing on that emergency department, making sure that there's timely follow-up, making sure that after an inpatient discharge, that transition is smooth and that we understand and that the patient understands what are their discharge instructions? Do they have a follow-up appointment? Is there resources they need? Or did something maybe get missed? I know Cheryl has plenty of patient stories that she can probably share about patients that, maybe something was incorrectly written on the discharge instructions. And if that doesn't get fixed, if nobody catches that, that goes to, maybe they went to a skilled nursing facility, that can be dire. And who knows what that patient's experiencing. So really making sure that we have that kind of quarterback that's sitting behind the patient and saying, okay, this is where we need to go. This is what we need to do. Here's what you need to know, and really trying to help them. Our other bucket is our total wellness care, really trying to go more into that specialized condition-specific programs, which is where we'll focus today a little bit, talking about chronic kidney disease, but really making sure that we are not just worried about, oh, they're coming out of the ED and we need to transition them. There's a lot of opportunity there, but there's also so much we can do for patients based on their specific conditions and specific programs that we can build. So we have to have these specialized options to really give them that support. And then lastly, our continued care, really focusing on that post-acute, and then also remote patient monitoring, because that can be very important. But really making sure that we are enabling the provider, we're enabling the care team, and enabling the post-acute facility to know as much, be coordinated, be working together as a team, and really making sure that we are helping that patient have the best experience as possible. Because that really, at the end of the day, at the heart of it, of what we are trying to do, that's the goal. Really help them have the best experience possible, have the best outcomes as possible, and that will lead to success for the value-based care arrangements. So again, really appreciate everyone joining today. Excited for the discussion. I'll turn it over to Cheryl here, talk a little bit about some of the outcomes, and then we'll dive into chronic kidney disease.
Okay, so really excited to share some of our outcomes as we have focused on our different programs in general, and as we have dived into developing our different programs, we've really tried to look at our population needs and to develop those programs based on what the population is needing or what they're doing. So this is an example of one of our programs. We really focused on understanding why people use the emergency department when they have other options of care. And so we've set up some different interventions to really help those individuals, whether it's somebody who's a high utilizer who goes to the emergency department because they have anxiety and they just need somebody who has a lot of high touch, or they're not really established with their provider well, and to really help them engage with their provider so that we can help them to get the care where they really need to have that care. And so the avoidable ED visit graph just shows you over time how we have been able to really help this population to start to use the ED more appropriately. And so year over year, we've seen that trend decline. There is that 2021 decrease there, and that was attributed to COVID. We did see a bounce back up, but it was still below the general trend line, and we continue to see that avoidable ED visit go down, and that's in conjunction with we did have some provider disruption within our network there in this area, and but we were still continuing able to help our population to again use the ED departments appropriately. And then the graph next to it shows trends, and this is our full population, which we've had different populations come in and out of our program. And again, we really try to reach all the different population to provide that education on using the ED. An example of that was with our commercial team. We saw that they had a high utilization for UTIs. And so we did a UTI campaign specifically for that. And we saw a significant reduction in people who use the ED for UTIs.
It's also more impressive in that our market had an increase from 2 to 7 of freestanding EDs. And so some of this success is in the face of a great deal of capacity. For those people who watch Field of Dreams, if you build it, they will come, and ERs are no different. And so what the care management team was able to achieve in the setting of a great deal of excess capacity is more noteworthy. Thanks, Cheryl.
Yeah.
And just real quick, I'd like to highlight, we got a question that came in asking, what methodology are we using to define an avoidable ED visit? And welcome Dr. Silverstein to jump in here as well, because we worked a lot with Innovaccer closely on this using the NYU algorithm to define our avoidable visits. Dr. Silverstein, is there anything you want to add into that?
No, that is, and obviously there's advantages and disadvantages to that, and I think all of us can appreciate there's nuance. Fortunately or unfortunately, I think it's good to, while the NYU model is obviously not perfect, it does give a good directionally, so you can have some reasonable confidence that it's reasonable.
All right, thanks for that. As we have worked on our different programs, as Jake's outlined there, we did see some significant outcomes for financial value for the programs that we're providing, whether it's our transitional care, our ED program, our post-acute SNF program. So we've had a significant reduction in readmission, which generated a $5.27 million in savings for us in reducing those readmission costs. So just talking about specifically the engaging of our population for transitional care services following an inpatient stay. So we were able to specifically with this group to reduce readmissions. And so we identify through an algorithm set up through our Innovaccer platform to identify those with the highest risk. So when we say that we have lowered our readmission rates from the general population, we're speaking of we put out the highest risk folks for readmission. And so their readmission rate is actually lower than those who would have a lower risk. And so we count that as pretty significant in the population and the work that we're doing for engaging these high-risk patients to help reduce that risk of readmission. When we're engaging our folks, we have different resources that we use within our platform, Innovaccer. So we have a couple different strategies. One is we target our high utilizers. So we have identified within our population people who use or have the need of using acute care, whether it's ED or whether it's an inpatient stay where they've gone in and out of post-acute centers. We're able to pull this information and we really work to engage them into our complex care management or other services such as chronic kidney disease so that we can really help to give them wraparound services. We as a team provide an interdisciplinary approach for our high utilizers and include the PCPs in that engagement. So we'll reach out to the PCP, their specialist, and try to really become a collaborative approach to helping these patients to get the healthcare that they need. We also assess them for their SDOH needs. We work well with our community based organizations to help them. We also have different benefits that we also provide to our ACO members, and so we make sure that we're connecting services to them. And we also have on our team, we have some social workers, we have a behavioral health nurse specialist. So oftentimes we see people with anxiety, depression, or even substance abuse issues who are using the ED or having increased needs. So we make sure that they're well connected to those services to provide that additional help. And then within our platform, we use risk stratification, and we have pulled out different markers so that when we have a specific group that we see that are needing help, and we see that they're high utilizers or they have high costs. Chronic kidney disease is an example of that. They are a small volume of the population, however, they have a high cost of care. And so when we're looking at our different populations, we're looking at both cost of care and who's needing services. And so we do that through our risk stratification. We're able to pull that out and to offer services. We also build our programs based upon those needs, whether, again, it's whether high utilizers, it could be, or specific disease processes. So in developing our chronic kidney disease, we again identified some outliers through our risk stratification and claims analysis. And so we were able to pull that data out. We're able to utilize our population health tool, and we were able to identify the population that we really wanted to target for our program. Then we also, as we were developing our chronic kidney disease, we wanted to identify who was going to be eligible for this targeted approach. Who did we most want to engage? And so we identified some key markers within the data that we would offer and provide these services. One of those is the GFR value. So within the Innovator, we are able to, with the integration of the EMR, be able to have access to GFR levels within the profile, and so we can get that information. And so we use that as a trigger for how we're going to outreach our population, as well as we identified triggers for including the pharmacist. When we wanted to include the pharmacist in reviewing their medications and do that as a collaborative approach. So we created a program, and in the program, we've identified screenings and gaps in care for these individuals so that we can really help coordinate their services and their care. We've identified the level of engagement that they potentially may need based upon where they are in their chronic kidney disease and how they're doing with those screenings and that type of thing. And then also we've created activities based on this stage. What kind of conversations are we having? What type of educational tools are we providing? And that type of thing. So Shannon, did you want to add anything to that?
I thought it'd be useful to look at where this can happen, and we're going to look at how the program was built. So where do some of our medical economics and nursing and other team members come together? So this is an example of where we would do a reach out. We manage, I'll discuss a large 30,000 member plan. So we had a 58-year-old male dependent of the subscriber from Laos, and he had limited access to medical care prior to his ER arrival, which sadly was for the development of hypertensive kidney disease. The kidney market is a very strange one in terms of a duopoly to some degree of two kidney facilities that have a great deal of control over the market. And both of those came in at greater than 1,500% of Medicare charges, not a typo. And they also reserved the right, if they exceeded the cost that was paid by the plan, to balance bill the member. This occurred on December 22nd, and By December 24th, our team was able to work with the inpatient discharge planners to be able to secure an in-network dialysis at 300% of Medicare, and only in dialysis does 300% seem like a steal. But we were able to succeed in getting that done and discharging them on Christmas Eve to an in-network facility. This benefited certainly the plan that we represent, but also benefited the member who was insulated from getting out-of-network balance billing. This takes a lot of coordination, and this is hard even for most plan-based, and certainly most hospitals are focused on getting the person out the door. And I understand that, especially depending on their bed pressure during at this time flu season. But it takes a team in the back of care management to help with coordination, with being able to understand the network and getting the person placed somewhere effectively. And we'll go through where we came up with the idea to start with a focus on CKD in the next several slides. Next slide. So we're going to look at what we did for a large Washington employer. It's a self-insured plan with 31,000 members and with a spend of about $300 million. And we built, and I'll explain the business case, a team involving medical director oversight, 2 managed care pharmacists, a nurse with several years of experience in a dialysis center, and likewise a social worker that was formerly employed at a dialysis center. Next slide. Here was the business case that we looked at with the plan. This is a plan of, at the time, 24,000 members. It's grown somewhat, and less than 0.5% of their individuals had chronic kidney disease 3 through 5. And the majority of those were in the 3 up to a small number of 18 of them on dialysis. At the time, the plan was about $180 million. And what was discovered, no surprise, is at each advancing stage of chronic kidney disease, the monthly PMPM increased to perhaps 5 times average for somebody who had CKD3 up to, again, not a typo, 45,000 PMPM for the 18 people on dialysis. So here we had about 7% of the entire plan budget going to 0.5% of the individuals. A lot of things in medicine aren't predictable. Traumas, certain types of cancers that are not really preventable and are certainly hard to avoid. What can be usually prevented and avoided is progression to dialysis. There's rare exceptions, somebody with sarcoid nephritis, but the majority of individuals have need for dialysis due to high blood pressure and diabetes, both of which are controllable, both of which are tenacious chronic diseases. And we thought to ourselves, if there's a predictable slope that can occur, is there anything we can do to slow that slope, to build a team to intervene for blood pressure and sugar control, to try to slow the progression of people from moderately expensive stages 3 to 4 to positively usurious spends in stage 5. Next slide. So what we did was we brought on a Pop Health CKD focused team, the membership of which I discussed. The nurse and the team scan for people, as they do every day, who've been in the ER and hospital to see, is there somebody here with a CKD diagnosis that we didn't know about? Separately, the pharmacist uses a Pop Health tool, for us it's Innovacer, to find CKD 3 to 5 patients. Majority of people with stage 5 are seeing kidney doctors, but at least in our market, there is a shortage of nephrologists, and most stage 3 is not seeing nephrology. And we created the database, and the pharmacists were able to check simple things like ACE-ARB if they have albuminuria. 20% of people weren't on these. Are they on an SGLT2? Are they taking a statin? Are they doing it for blood pressure control? Dr. Silverstein and I were both internists first, and most of us are comfortable doing this, but I must be honest, I was less comfortable doing anemia management, erythropoietin, and other elements. Than finerenone for appropriate patients. Next slide. What we also did was partner up with our medical economics team. There are a lot of drugs that slow kidney disease, some of which are quite expensive. And the question comes, if you're sitting with an employer saying, do I want to use pharmacists to start people on this drug? The question is, does it have some sort of economic payoff? And we did a study with using dapagliflozin or Farxiga. We have no relationship with them. They helped us a little bit poster, but we have no relationship. We just said, here's a drug that costs $600 a month. A lot of money. But we have a condition that costs a lot of money in the form of CKD, and this also helps with heart failure. Next slide. What we were able to look at in the green was the experience without the drug. The magenta was with the drug, including the cost of the drug, and the black was the savings. Looking at over $3 million over 3 years. Again, focused on just 100 people. So if our pharmacists could get 100 people to take this drug, we would save almost $4 million over the course of 3 years. That's a pretty good payoff to make 100 phone calls. And so we were able to reach out and find a way to say, certainly we want people on $4 ACEs and ARBs, but in this case, it was worth it to say we will hustle down these people to slow that trajectory and save the plans entrusting us with their resources money. Likewise, certainly dialysis is an expensive condition, saving the member money and the incredible life-changing experience of being on dialysis. Next slide. So we'd love to invite folks to discuss where they see this as an area of interest or how to build it. We focused on chronic kidney disease because we saw that as a chronic condition with a large behavioral component, with a lot of care coordination, and there's certainly other areas like COPD and heart failure where we've done a lot of work with remote patient monitoring, patient education. We know a lot about managing our populations in Washington and the surrounding states. What we don't know is what you face, what roadblocks you have identified, and likewise, areas where you may have had success that we haven't. And we would love to have questions on what can be done in the care management space. I'll turn it over to Jake.
Yeah, we'll turn it over to our discussion moderator, Dr. Silverstein.
Yeah, thanks so much, Jake, and certainly excited to be here. And while we're waiting for some questions from our audience members to come in, then I thought I would just get us started. Love the examples that you shared here, and I've got an opinion on it, but would love to hear yours. When you think about different care management programs, what's the right play? And meaning that everyone has limited resources. You look at the patients with advanced disease, you look at the patients with perhaps, early stage disease, and there's different strategies for each. But if you're thinking about, I only have, X amount, then what should I do? What should I go after first?
Reasonable question is, what specialty are you most lacking? And that sounds like a silly question, but every market is different. We have a 9-month wait for neurology and 8-month wait for endocrinology. So are we going to start with diabetes and try to get a handle on chronic migraine ER visits? Yeah, we have pretty good access to pulmonary. We are doing a COPD pathway because there's so much patient education involved. But I think it depends. Tip O'Neill, the Speaker of the House in the 80s, said all politics is local, and so is every medical market. I think it depends on where you have the greatest gap in specialty access. And also, having been an endocrinologist, there's only so much diabetes education I can do in 15 minutes. So I think it depends on what you're most missing, and partly it's going to depend on what your group has for an interest or talent. Why do we start with diabetes ahead of migraines? Because I'm an endocrinologist. You'll notice as a former geriatrician that I did not start with peds. So it will also depend on where you folks have your own strengths and also where your team has for strengths. Who would have figured we'd get a dialysis social worker coming onto our team? So arm yourself with what you've got, see where your spend is. Maybe your market does not have 2,000% of Medicare charges for CKD. Okay. But maybe you have something else, like someone has a lock on your sleep apnea market, and that's where you want to be. Other thoughts, Cheryl, or is that covered? Okay. I think we had one come in, but I didn't. Oh, Brian, I take the liberty of, or I think there was a good question about the medication. Can I? Yes. So both of these are related to the fact that these drugs are not inexpensive. Do I have great news for you? We liked the drugs. We liked dapagliflozin at $600 a month. In a year and a half, they are going to go generic. And I like them at $600. I'm going to really like them at $10. So but you are correct. My father was a janitor, and I think his retirement was about $2,000 a month. And if you sit with somebody and say, this drug is going to cost $50, and that represents 3% of every dollar my dad had to live on, That's a real question. We do help with the medication assistance programs. Our pharmacists for sure can help with that. These drugs are better covered than they used to be because we have three medical economics actuaries. Insurers have a lot of them. And because these drugs save money, they are typically a tier two cost. Finerenone tends to be a tier two for the simple reason that there's only one in the class. I'm sure the next time one arrives, one of them will become more expensive. So they're not free. I agree with you. They're not $4 lisinopril. So our nurses were able to help, especially our pharmacists were able to help people try to understand their benefits. That being said, people have donut holes. I did geriatrics in the early 2000s before there was a donut. So everything is useful for perspective. People will say, but I haven't heard him with the donut hole. And just some perspective, there used to be no donut. But it's a fair question to ask, and our team does help with the medication costs, and you are right to point that out. And keep an eye out for dapagliflozin and empagliflozin Jardiance, who will both, I think, be generic in the next 18 months. I have never gone wrong with the skill of companies' patent lawyers, but I think those look like good dates. Sorry, back to you, Brian. I just saw those pop up, and I knew it could
No,
answer.
absolutely. Thank you for answering them. I appreciate it. I think that's fantastic that we're able to get those. And please keep your questions coming in. We're excited to hear what they are and make sure we get the information to you that you want. While we're waiting for some additional questions to come in, I love that we have a chance to feature. These are some amazing success stories. But all of us that have done this know that the way you get the success is you try a lot of things that don't work. And so would love to hear some of the stories of things that we've done that haven't worked. I think that it's good for people to realize, just how challenging it is and that you do sometimes have to work through a lot of things that don't work to get to something that does.
Cheryl, can I take on the UTI campaign's difference in age, or would you like to take point on that?
Oh, sure, go ahead. That's a great example of a campaign that we started. So yeah, please share that.
So Cheryl and entirely her team built a UTI education campaign, and Cheryl and her team built one to focus on ways to avoid UTIs. Great success in dropping the use in commercial patients by 12%. You know what didn't help was Medicare patients. When I did geriatrics, Medicare patients get different types of UTIs. Some of them could be catheter related. They are not typically the swipe and wipe education that we would give to young women. And the education campaign worked really successfully in commercial, but Medicare patients, we did not see much of a budge. And so we stopped focusing on doing that same campaign for them. Seemed like a good principle. They're all UTIs. But the answer is different people have different conditions. And there was one where it worked for one group, didn't work for another, and we stopped doing it in the group for which we had little success. So there's an example of awesome idea that doesn't apply to everybody.
That's a great example and really highlights too the importance of understanding your population and really that first cut is what's the population we're taking care of and what are the issues that we're facing and identifying the right programs based upon that. So we've got another question that's come in here. And are you finding a large number of payer-based CKD programs popping up? And how are you collaborating or managing these programs who are outreaching the patients on behalf of the payer? And perhaps why don't we broaden that question? Because I think that's a common issue is that depending upon the disease and condition, a patient could be eligible for multiple programs. And so how do we, so let's hear the answer to this as well as how do we coordinate in general?
Great thought. So if you were to say, what do you do in-house and what goes external? We actually looked at some of these. Cricket, Stride. We looked at some of these for our insured people for chronic kidney disease. And we looked at this and I thought, why would I outsource this to build? And the answer was, we have the in-house talent. It's easily predictable. Would I be more excited to work with a partner in an area that I don't understand, like spine? Boy, I still don't understand spine surgery in terms of who goes to PT, who gets injections, a lot of money there. I don't have a lot of in-house expertise. And Cheryl and I together between our teams do not have a lot of experience in trying to remotely manage. Her team does some education, back safety, where to go, when to use physical therapy, do you need rides to appointments? but we don't have a lot of in-house expertise to manage that. But you are correct that our local Blues plan or Aetna we have Costco in Washington State has Aetna. Is there a world in which Costco says, hey, employees, here is your chronic kidney disease plan? We find uptake of those to be fairly modest for employers. For that self-insured plan we manage, they use a diabetes virtual vendor. We said, have at it. We have a 9-month wait for endocrine. You could be in a world where someone else is using a Cricket and we have ours. If somebody's in a CKD plan, that works for us. We generally have seen limited uptake. There's some spaces like weight management where we do see some usage. We don't see good persistence with those. So they're there, they're real, and if we have a decent sized plan of 30,000, we are going to know what they're offering. Or perhaps one of our Medicare Advantage plans offers silver sneakers or a certain gym membership. So our team will be plugged into that. Cheryl, are there any other examples you can think of where we ran into some overlapping territory? Those are the main ones I could think of, but any other COPD payer-based ones? I can't think of any.
So we have had different examples of where our team has been reaching out to a population and somebody else is outreaching to them. We've seen that in COPD where they're going to pulmonary and their team is also reaching out. One of the things the team does is to evaluate the services that they're receiving and how well they're being managed by that service. What we found sometimes is they get a monthly call that's the 20-minute call and that's it. They're not getting the full collaborative services and all the education that they need. And so we'll outreach with them. And or if we find that that individual is receiving enough support services, then we'll collaborate on the back end with whoever's providing that service. So we just make sure that they're getting everything that they need before we step back, regardless of what type of program that it is.
I like that. I think that collaborating on the back end is so important. I think, to your point, Cheryl, we've seen that, maybe, in our circumstance, right? We don't, as PSW, employ any providers. We're working with providers that are out in the community. Well, they might have a care management program, and then we have a care management program, and then the plan might have a care management program. So making sure that we coordinate on the back end, that we try to have a single experience for the beneficiary because it's already confusing enough. How do we make sure that we navigate that to make it easier for them? And so I think opening those conversations, to your point, managing and understanding the effectiveness of each program, but opening those conversations and trying to make sure that we are working together, that we're truly coordinating that care for that beneficiary is so important.
We do employ physicians. They just tend to do most of their work in flight on Alaska Airlines versus anything on the front line. Those of us but yes, to your point.
Yeah.
I think another aspect of that is really ensuring that there is the patient education piece for modifiable risk factors, as Dr. Shannon was talking about, managing their diabetes, managing their blood pressure, so that we can make sure that, they're achieving their best health outcome. And oftentimes, they're not receiving that information and they're not understanding the impact of their own health habits, their behaviors, and how they're affecting the progression of their disease. And so that's something that's really important to us in care management, that they have that understanding for shared decision making as they're going through that.
And Cheryl, maybe if we want to build upon what you were just sharing there, I think that's a common thing with programs is what really is the patient's role. And so how do you actually engage patients? And when patients are, there's this whole notion of I think it's the terminology is at times it's not the right terminology, but compliance with programs, compliance with different things. So what's your perspective on the patient's role and what you do when patients are not engaged?
That's a great question. So our philosophy really is to educate the person to make their own decisions regarding their own outcomes. So you can't do this behavior and want this outcome. They're not going to happen. And so to make sure that we're providing that information. So, if you want to live a long, healthy life, or you want to slow the progression of the disease, or whatever that is, that they have the information to make that decision. And what they do with that information is up to them. They're the ones who, at the end of the day, are accountable for their own health. And so we want to make sure that they understand that, and they have the information that they need, that they have the resources that they need to make those decisions in how they're managing their health. When we have individuals who are high risk and they're not engaging with us, we again collaborate on the back end. So we're calling their PCP, we're calling their specialist, and we're encouraging them to engage with us. We educate the providers about our program, why they would want their patients to enroll with us. And so we found that very helpful. We also send them information in the mail. So you're not going to answer our phone call sometimes, because a lot of people these days get a lot of cold calls. There's a lot of crazy things going on out there, and people don't want to answer the phone. And so we found that by providing them information about our program before we even call them, that connects PSW to their health plan, they'll actually even call us and say, can you tell me more about this? And so we found that to be a great example of improving engagement for the population.
We do a lot of motivational interview training, and we have a pretty robust clinical training by one of our physicians with some experience in it. I'm not going to quite land Mark Twain's quote that a habit's not to be tossed out a window. It's meant to be coaxed down the stairs one step at a time. And for a lot of these individuals, my dad, who I think most green he ever saw on his plate was lettuce, is you are not going to convert my father into a vegan, or at least it's going to be many steps at a time to get him there. And Cheryl's team, especially on people, can you check your sugars twice a day if you can't check it 4 times a day? I think Cheryl's team has had success in trying to find people of where am I going to be able to find you on this? Especially her team on smoking cessation has done some really strong work on meeting people where they are and getting them where they need to be over time.
Yeah, I think that's kind of a key thing that I've experienced too, is a couple things. One is the whole notion of how you can do different behavioral techniques. I remember there was a patient once who, multiple ER visits for dialysis, for not showing up for dialysis. And it turned out the patient actually just had anxiety and when they were going to dialysis, and the solution was that the patient was an artist. And so by providing them with some crayons and paper, then that actually solved the problem. And it was a care manager who kind of figured that out, despite the fact that there were, multiple physicians and other professionals involved. And so it's like that engagement element, tapping into the patient, I think is critical. And as you were saying, Dr. Shannon, the ability, rather than shaming people, it's progression. And so moving towards, okay, that we understand that this seems unreasonable to you. What is reasonable to you? Okay, great. Let's start there. And then tying into what do you see as an outcome you're hoping for, and tying that together. Because, most patients don't care about their lab values. What they care about are different functional and outcomes. And so being able to correlate the two can be pretty powerful.
Yeah, we had a patient who was going to the ER over 300 times in a year. And so we had a nurse care manager who called the person almost daily, and that rate dropped below 50. So, it was still an excessive use, but it was significantly impacted by just those daily calls with the nurse. So, yeah.
We had a 98-year-old who had about 30 ER visits a year for anxiety, and she was mostly blind and deaf. And so I had this idea. So she would ask her 70-year-old daughter to take her to the hospital whenever and I felt like it was just a lack of sensory stimuli, like your artist. And I had the idea to get her a cat, and it worked, but actually in a way you wouldn't expect. Essentially, the daughter got so enmeshed with the cat that the daughter just stopped bringing her to the ER, and just would sort of learn to deal with this. it got our visits down, but the mother who could hear my low register voice, so I ended up talking to her. The mother said that the cat was quite delightful. But yeah, this is a part of troubleshooting that you end up where somebody has some barrier, and the answer is I don't have two of my senses. What can I do to stimulate the third? Or in the case of you giving someone art supplies. This is most of the troubleshooting. If it was all could all be done by a computer, somebody would have automated it by now. So yeah.
Yes. Well, there's certainly some interesting hopes for the future with that, but the automation to date has not been sophisticated enough to be able to get to those levels, but we'll see. Um, Speaking of that, one thing that I would love to hear about is how you measure success. Obviously, there's some great things here in terms of cost savings, and that's great. I think a lot, if we're able to save patients money, save employers money, save risk-bearing entities money, that ends up those resources could then be redeployed in a variety of other ways. I'm curious though, when you think about what outcomes are you going for, what are the different, how do you decide what measures you're going after? And tell me more about that.
Cheryl Mosses, who could make graphs to rival Accenture. Would you like to discuss some of the reporting metrics you use?
Sure. So one of the things that we're looking at is how many those who crash and end up on dialysis and from a hospital setting. And so we want to be able to identify those individuals who are at risk and to help them navigate the process so that we can reduce that impact to the person. So not as an only a financial thing, but you think about the person who that happens to. And so we consider that a significant success. Also, utilization trends for those with chronic kidney disease because of comorbidities. So we've talked about how there's comorbidities involved in CKD and how we're managing those. And so looking at their utilization and how their health is going, that's another success. And again, it's not just on a financial impact, but it's an impact to the person who's going through those things from the health perspective. So also we're looking at other options and helping the individuals to make a choice that's meaningful to them. Do they want to do home dialysis or are they going to do it in a dialysis center? So, making sure that they have all the information to make the choice that's best for them before it gets to a point where they can't make that choice.
Fantastic. So I know we're getting close to the end of our time together, and thought it would be a good idea for us to kind of think a little bit about the future. And so obviously we've got a lot of programs in place, we've got some great results. As you think about the future, what are some of the things that you're thinking about from an aspiration as well as from a practical perspectives?
I'll start with what the nut we haven't cracked is how to use big data for social determinants of health. I did geriatric primary care before endocrine fellowship. The biggest predictor I have found for hospital admission for elderly men is the death or departure of a spouse. And I took care of a lot of World War II veterans early in my career, and some of these gentlemen had never made food. They said, I left the service and they fed me, and then I got home and married Martha and she fed me. And they would inevitably come into the hospital within a week with either hypoglycemia from not eating on the same dose of insulin or in flash pulmonary edema because all they could make was soup and some of them could not reheat it. They were having cold soup with 10 grams of sodium serving. I can figure that out clinically in the room. Can a computer pick that up or food does? Or there's some elements, and Cheryl's team's done well with some of the area deprivation indexes. What it can predict is my friend moved away or some other elements or my niece no longer lives near me. I think it's hard to pick those up, and Cheryl's team does the best, but to put that into discrete data that can be extracted, I think is a challenge. Cheryl?
I 100% agree with you, Dr. Shannon, on that. Those life impacts on people and how they are affecting people is really key to understanding, how it's going to affect their overall health and well-being. And so that is a challenge.
I'm sure, and if you ask me what do I hope Innovator goes into next, it is helping us, and it's hard to extract it, but help there's no way Innovator can figure out how many friends you still have and whether you go to the Elks Club anymore, but there's ways to get close. And it's going to be hard, but you've delivered on everything else. Thanks.
Yeah, well, that I think that there is a lot of excitement for the future, and there is actually a relationship we have where we're getting a individual feed for SDOH data in addition to all the standard ones with the ADI that CMS is using. And I do think that some of the early models using that for different risk predictions, readmission, admission, things of that nature are pretty interesting. And so looking forward to being able to hone and on the programs to get them to be even more effective. So really appreciate all the great work you're doing and all the patients that you're serving. And I think at this point we're going to bring our conversation to a close. We're going to have a feedback poll that's going to pop up momentarily if it hasn't already. And so please let us know how we did, if this was what you were expecting, and also what else you'd like to learn about. We love having the opportunity to engage with people. So, Jake, going to turn it back to you for close us out.
No, wonderful. Thank you so much. That was such a great discussion. A lot of, great nuggets, great elements that I think people